Hello, welcome back to Oral Surgery Board Review. Today we're going to be doing a whole bunch of TMJ questions. This is meant as a continuation where our previous two lectures we talked about TMJ Part 1 and Part 2. We went over the anatomy, the pathophysiology, and a lot of the procedures. And we're going to be filling in the gaps we're going to be reviewing a lot of what we talked about, plus we're also filling in some of the gaps of maybe some stuff we didn't talk about, and it's all based on old published questions. This is an important point as a preface. I don't have any secret bank of memorized questions or anything of that sort, although I kind of wish I did. These are all old published questions. All right, and with that, let's jump right into it. This is going to be a long lecture, so feel free to take breaks and come back. But let's jump right into it. I broke it down into various subcategories, and our first one we're going to be talking about is pathology. So let's first start off by reviewing what the Wilks classification was. So question 1, what statement best describes a Wilks class 3? So if you guys remember what was a Wilks class 3, that was the first one where it went from reducing to non-reducing, the first one. So if you look at the answer choices, C and D are both reducing, so that can't be either of those. Reducing is only a Wilks 1 or 2, so that can't be right. So let's cross off C and D, and that leaves us with A or B. Is it a non-reducing disc which is chronic, or is it a non-reducing disc which is subacute or acute? So the right answer there is it's B. It's a non-reducing disc that's subacute. And here's our chart just to remind ourselves. So here, 1 through 5 starts off with early, intermediate to late. And you remember 3 was the first one where it starts off. It's the transition. It goes from reducing to non-reducing. But I wouldn't quite call it chronic. I wouldn't call it choice A. I would call it subacute or acute, because chronic would be something more like over here, which would be a Wilks 4 or a 5. All right, next question. The findings consistent with a Wilks 4. So again, let's see how well you know that chart. So let's read through the choices. Which one of these is a Wilks 4? Is it a recent progression to disc displacement without reduction? Nope, that's a Wilks 3. We just reviewed that one, so it's not that. Is it a MIO less than 25? Well, it could be, but any of them could be, right? Wilks 3, 4, and 5 all have diminished MIO, so it can't. That's not specific to 4. Let's read choice C, altered mandibular condyle morphology. Well, that sounds right. If we remember, what is 4? 4 is the first time where you have degenerative remodeling of the bony surfaces. So 4 is the first time where you have bony changes. So C sounds like a right choice, and D, well, that has nothing to do with it. So that's kind of just out there to confuse us. So the right answer is C. All right. Which statement is true about internal derangement of the TMJ? So this is actually a tough question, and we didn't talk about it before, but it does make sense, so let's go over it. So they're asking you which is more important, and a lot of the choices are, is position more important or mobility more important? And the truth is, the right answer is mobility is more important than position. And you're gonna ask yourself, no, I don't believe you. Wait, that sounds very counterintuitive. You just, for the last hour, all we've been talking about is position, 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 right? We talk about abnormal positioning, and internal derangement is defined by being anteriorly displaced. A lot of the procedures are designed to reposition the disc. So all we keep talking about is position. How come now you're telling me mobility is more important? So I didn't believe it until I looked it up, but the studies have shown, and they've done studies on this, and the mobility is more important than the actual position. And now as counterintuitive as it seems at first, let's try to make some sense of it so that we can memorize this for the test if we ever come across this question. So let me just read this to you. Although the position of the disc has been discussed for years, some of the issues that the disc does not need to be in a normal position for patients to be asymptomatic. So that's an important point, right? We know that patients can have an abnormally positioned disc and they still could be asymptomatic. So it shows that it's not particular to the disc position that they have symptoms. The mobility of the disc seems to be more important for the health and the functioning of the disc. We also, in that, from what we understand, the mobility of the disc is what helps the lubrication of the disc and the different anabolic and catabolic processes. So we understand now the mobility to be more important than the position. But that was a tough question. All right, question 4. What percentage of adults asymptomatic have internal derangement? So this is, piggybacking on question 3, right? We know some patients, some percentage of the population will have internal derangement, meaning they'll have an improper position, but they have completely no symptoms. And the answer is it's 30%, about a third. It's a lot. So disc displacement found in asymptomatic patients about 33% of the time. A different question that I once saw was, what about in kids? What age does that tend to occur in? Is it happening in young kids or adults? So they looked at kids 2 to 5, and none of them had abnormal disc position. So in case you ever get that as a follow-up question, ages 2 to 5, they're always, so it's not a congenital issue, it is a developmental issue. That's the point I'm just trying to make. All right, moving on to question number 5. A 12-year-old has, this is an interesting question, and you can learn a lot from this question. So there's a discrepancy between the dental midline and the facial midline. So the midlines are off. And they're saying CO approximates CR. So they're saying the condyle is in the right position, but the dental and the facial midlines are off. What is that consistent with? So let's go. We're going to immediately knock off A and C because it's not muscular at all. We know this has nothing to do with myofascial pain or lateral pterygoid. So it's going to be internal derangement. But the question is it right or left? So let me just show you a quick picture. So this is the first thing I want you to appreciate. When they say the dental midline is to the right of the facial midline, and I know in this picture I have it backwards, but let's just say anytime you have the facial midline and the dental midlines and they're off, that means there's a discrepancy between the vertical ramus height or the mandible. So there's a short side and a long side. So in this picture, my right side is the long side, and I'm deviated towards the left, and the left is the short side. So you're always going to deviate towards the left. Now, let me just back up. So in this question, the symphysis midline was 3 millimeters to the right of the facial. So the dental midline was to the right, which means the right side was the short. So in our picture, it's backwards, but in our question stem, the right side was the short side. And the important point to know is there actually is an association between having a short side and having internal derangement. So they did a study where they looked at this and they found that unilateral internal derangement occurred on the short side. That isn't a true association. The question why is a very interesting question. So subsequently I tried to find an answer. Why are we getting this short side? All right, so let me just read to you this a little bit. So 12 patients had facial asymmetry. It was thought to represent condylar hyperplasia, and then they found that 6 out of the 12, so 50% of the patients also had internal derangement on the short side. So whichever side is short, the disc is going to be anteriorly displaced. Now, why is that happening? And again, the only clear distinction was the presence of degenerative joint disease on the short side. So there is an association. The question is why? It may be like a chicken and egg situation. It may be which came first. So actually some studies are making it seem like the degenerative joint happens first and then the anterior displacement happens subsequently. So because of, they're saying here, because of the difference was attributed to mandibular shortening of the disc displacement side as a result of degeneration of the condyle. In other words, erosion and resorption was found in the condyle. So the short side, due to erosion and resorption, is obviously that became the short side, and that's why the disc is displaced. So anyway, it kind of makes sense. It all puts together. The short, because of erosion and you have a shorter condyle, and if you have a shorter condyle, then the disc is going to be anteriorly displaced. So anyway, going back to our question, patient had a discrepancy between his facial and his facial midline and his dental midline. That's going to be associated with what? It's either internal derangement of the right or the left. So you got to figure out which is the short side. So everything is deviated towards the right. If it's deviated towards the right, then you know the left is too big. It's pushing over to the right is too small. So the answer is going to be B. Internal derangement of the short side. All right, now this is actually, so that, I just learned a really interesting topic in question 5. And question 6 piggybacks on that, and it's kind of repetition just to hammer it home. So let's read this one. Which of the following skeletal jaw deformities is most likely associated with bilateral TMJ displacement without reduction? All right, so based on, if I'm telling you they're related, so guess based on what I just told you, which one of them is most similar. So it's Class 2, well, Class 2 comes in the first 3 choices in Class 3. So probably it's Class 2 if you're a good test taker, but let's think about it. Class 2 means you have short, right? Usually Class 2 is because you have a short condyle or a short ramus. And then the question is it a high angle or a low angle? Or is it asymmetric? So actually it could be B is attractive at first, but I'm going to tell you why it's not the right answer, because they're asking for bilateral. If it was asymmetric, that would be unilateral, right? It would be exactly what we had in question 5. If they said the person had a unilateral TMJ disc displacement, then B would absolutely be the right answer. You're thinking of an asymmetric class 2 malocclusion, but we're saying bilateral. So then I'm thinking, okay, it's either a high angle or a low angle, and if you see a picture, you'll see right away. So let's just review this for a second. What is high angle versus low angle? This comes up in orthodontic surgery. We talk about it all the time. So we define the mandibular plane angle or the occlusal plane angle, both very similar and overlapping with each other. Usually when we talk angle, we're talking about mandibular plane. So for now, let's just talk about mandibular plane. In relation to SN, SN would be the Steiner. There is a relation to the FH, the Frankfurt horizontal, but for now let's use standard. So the Steiner says 32 degrees from the mandibular plane angle to the SN, to the cranial base. So that's a normal mandibular plane angle. And then we have a low angle and a high angle. So a high angle would be a more obtuse angle, so like 39 degrees or greater. So if you widen that angle, that would be considered a high angle. And as you could appreciate, if you have a higher angle, well, then you have a shorter ramus. And so let me read this to you. TMJ internal derangement should be suspected in any of the following situations: mandibular deficiency, yep, short mandible, symmetric and asymmetric class 2, so we already talked about that, vertical ramus deficiency, and anterior open blight. And all that totally makes sense based on everything we just said. So if you have a short mandible, you open up your angle, and if you open up your angle, you get an anterior open bite, and you're going to get vertical ramus deficiency, you're going to get mandibular deficiency. It all totally makes sense, and it all comes together very nicely. So anyway, so going back to the question, which one of these is associated with internal derangement? The answer is class 2 malocclusion with a high angle. High angle because that will lead you to a short ramus and an anterior open bite. Next question, question number 7. And finally, let's get a little bit easier. Which of the following is the most common complaint in TMJ patients? Actually, I'm not sure this is easier. This you kind of just have to know. So let's go through the questions. Pain with opening, that sounds attractive. Open lock, no, that's probably not the most common. Headache, that does sound attractive. And tinnitus, no, that doesn't sound. So I'm between A and C, and I'll tell you, I know the answer. You may not have guessed it. Actually, it is C. Headache is the most common. The next and equal to headache is pain upon mastication. So if they would have said pain with mastication, then A and C would have both been correct. But pain with just plain opening, not with mastication, just opening, that's a slightly less common. They did, prevalent studies based on patients with TMJ pain. Headache is the most common, equal to pain upon mastication. Followed, the next most common is pain with opening, and then open lock is actually pretty low on the list. All right, let's diagnose this. What do you see? Open and closed. What do you see? So let me just review how to read this. We got to first identify what we're looking at. We're looking at an MRI, so let's just follow this cursor for me. You see this black rim? That is the condyle, and it comes out black because that is the cortex. The cortex is always black. The inside is the medullary cavity. Okay, so here is the mandible. Now, you see this shadow, kind of looks like a bow tie. You see how it looks like a bow tie? You kind of superimpose that. So anyway, that is the disc. And you have to see the disc is here and the disc is here. And in both cases, the disc is anteriorly displaced. And that's the point. It's displaced anteriorly, both in the open and in the closed position. So which one are you going to choose? You're going to choose displacement without reduction, right? We talked about this last time. Reduction means the disc assumes the normal position. And we see in this case, both in the open and in the closed configurations, the disc is displaced. So choice B is the right answer. All right. Next question, number 9. Marked degenerative TMJ disease has been associated with which condition? This is interesting to know. So I don't expect you to know this, but it does make total sense. The answer is hemophilia. And why does it make total sense? Because patients with hemophilia are more likely to bleed, they're more likely to get hemarthrosis, and we know anytime you get blood in the joint, you're going to get degenerative joint changes. So hemophilia, hemarthrosis, totally makes sense. Question number 10. A 46-year-old female presents with bilateral pain, restricted jaw movement, slight apertonathia, that means open bite. CT and MRI show erosions. Oh, so she sounds like a bad case. Joint effusions. Her fingers are swollen. Pitting fingernails. Nail dystrophy. Negative rheumatoid factor. HLA is positive. She's anemic, and she's got ESR elevated. What do you think the diagnosis is? All right, so this is a good medicine question. The answer is psoriatic arthritis. How did I know that? So I'll tell you, it's actually, you can rule it out. The choices are, it's not gout, HLA positive shows up in 2 of these choices. So just based on that, I kind of knew it was psoriatic arthritis, but it could have also been ankylosing spondylitis, but it just didn't fit the vignette. Usually when you give you ankylosing, that's usually like a young kid, a teenager, a male, and they have a stiff back. They say they get out of bed in the morning, so it didn't fit the vignette. But psoriatic arthritis definitely fit. It had the nails and it had the HLA. Reiter syndrome, they're going to give you a vignette of someone who had an infection, like could be an STD or chlamydia or Shigella, and then a few weeks after that, then they're going to get joint pain. So it's not Reiter's, it's not ankylosing, it's not gout, so psoriatic arthritis definitely fits. And a follow-up on that question, just for repetition, which characteristic is representative of psoriatic arthritis? So A, polyarthritis in a man, that seems like it could be the right answer. Does it affect 50% of the patients with cutaneous psoriasis? Maybe that's a trick. They're trying to get you to go for that one because they're thinking you're going to fall for that. Oh, psoriasis, psoriatic arthritis. The truth is, it's less than 50%, a lot less. It's only 6%. Only 6% of patients have actual cutaneous psoriasis. But anyway, ANA positive, rheumatoid factor? No, we just know from the last question that's not positive in psoriatic arthritis. That's things like rheumatoid arthritis or lupus. And bilateral with restricted opening? Yeah, that could be. So A and D seem right. B is completely to throw you off and maybe seems right if you're not familiar with that, but the right answer is polyarthritis in a man. So, like I said before, it's only 6% with cutaneous, so that was clearly to throw us off. And then D also was a little bit to throw us off because it's not bilateral, it tends to be unilateral. It tends to be polyarthritis, so it affects different joints throughout your body, but when it comes to your TMJ, it tends to affect only one unilateral TMJ. Which of the following findings differentiate osteoarthritis and rheumatoid arthritis? So this is a very classic question. I think you guys all know this. Prolonged morning stiffness, right? We ask the patients, does it feel better or worse in the morning and the end of the day? Osteoarthritis is because of chronic overuse. So every morning they wake up, having rested it all night, it feels great. And then throughout the day, it gets worse and worse. That's osteoarthritis. Versus the opposite is true for rheumatoid arthritis. The more they use it, the more they it feels better, but in the morning it's all stiff from not using it all night. So that's a perfect question to differentiate osteo and rheumatoid. That's a very classic medicine question, and probably you guys already knew that. Moving on, I forgot to number this question. What are we up to? I don't know. 29-year-old male presents with a slow progressing malocclusion and chin deviation. Okay, so before I even look at the picture, my mind's immediately thinking condylar hyperplasia, right? Slowly progressing malocclusion, chin deviation. I'm thinking it's a hyperplasia or some kind of growth or tumor. But then I look at the picture, I'm like, oh gosh, that's clearly a tumor. All right, you see the morphology on this condyle, and if I zoom in, you'll see it clearly looks benign. It's well circumscribed. So out of these choices, which was a benign tumor? The most common tumor is the osteochondroma. And if it was osteosarcoma, expected to be poorly circumscribed. So it's not osteosarcoma, and it's not condylar hyperplasia, even though it kind of sounds like it, because if you look at the picture, it just clearly is a tumor. So osteochondroma is correct. Question 13. A 20-year-old female presents with a previous history of TMJ clicking, isolated joint pain, and limited opening. Physical exam shows preauricular tenderness and crepitus. You obtain a radiograph. What's the most likely diagnosis? All right, so let's look at this. Could it be a psoriatic arthritis? It could. But they didn't mention any other joints. I would have expected them to mention some other joints in their body. Usually it's a polyarthritis, right? So not really fitting the vignette. And also it's more likely to be male than female, so again, not fitting the vignette. Avascular necrosis, no. Osteo, yes, that does seem like it could be, or rheumatoid. Well, they didn't give me any fingers, and rheumatoid, they're definitely going to give you some other joint, so I'm going to go with osteoarthritis. And the giveaway here was osteoarthritis tends to be chronic, and this patient, if you read carefully, they said she had a previous history of TMJ clicking. So the clicking started, but it was asymptomatic in the first, and then over time it just progressed to preauricular tenderness and crepitus. So that clearly fits the vignette of osteoarthritis. Question 14. Which of the following is a prominent feature in condylar hyperplasia? So you got to know the type 1 versus type 2. So I'm going to get to a chart. This is definitely, I did not talk about in the previous lecture. It is good to know. So let's immediately off the bat, we could rule out 2 of them are completely wrong. So ankylosis, that's wrong. Ankylosis has nothing to do with condylar hyperplasia, and everything else actually could be right. Deviation of the chin, that could be right. Bilateral crossbite is not right. No, D is wrong. You can get unilateral crossbite, because when you get, unless your condyles are bilaterally hyperplastic, but no, we're talking about a unilateral condylar hyperplasia. That's the only way you would notice it. Bilateral would just be symmetric growth. Anyway, so it's not, you would never get a bilateral crossbite from condylar hyperplasia. So we could rule out D and we could rule out ankylosis. Ankylosis is completely not true. That has nothing to do with condylar hyperplasia. So it's going to be either B or C. So as the condyle gets longer, you're either going to get deviation of the chin or you're going to get an open bite on the side of the condylar hyperplasia. So both B and C look right. The only way to differentiate it is to know the difference between type 1 and type 2. So as a review, or for the first time I should say, this is not so high yield, so I don't expect this to show up in the test. But Obergaser had a classification. Type 1 is in the horizontal vector. That's how he broke it up. And so basically you imagine horizontal meaning width. So it's getting wider. So if the condyle gets wider, you're going to get chin deviation and you're going to get a midline shift. And type 2 is the vertical. That's the length, the elongation. So in that case, you're going to get an open bite. So again, type 1 is horizontal, type 2 is vertical. How are you going to memorize that? Well, I think of this. This is a little easy trick for me. I think of like x, y coordinates. X is always horizontal, and then y is up, down, vertical. So type 1 is going to be horizontal. So the question I asked was, which is a feature of a type 1? So I'm saying to myself, okay, type 1, I know it's horizontal. The ramus is getting wider. If it's getting wider, it's going to be B, deviation of the chin to the contralateral side, and we got it right. Excellent. Question 15. All right, we're getting into headaches. This is very important. Excruciating unilateral periorbital pain, piercing pain, lasting 30 to 60 minutes. So the time course is always important to help differentiate it. Associated with ipsilateral lacrimation. All right, that gave it away. That's a buzzword. Hopefully you guys recognized it. That's going to be a cluster headache. So let's just review our headaches. Cluster headache, you're typically going to be given some story with about a male with rhinorrhea or lacrimation. Migraine headaches, you're going to get photophobia. Some girl goes into a dark room and feels better. Trigeminal neuralgia, you're going to get stabbing or electrical pain. And the time course, it lasts like 15 or 30 seconds. It's very short. All sorts of things could trigger it, like just touching your face lightly or wind even. And then finally, a tension or a stress headache feels like a band wrapping all around your head. All right, another question just to hammer it home. No, completely different question, sorry. Maybe we'll get more, later I may have another headache question coming up. But anyway, this is a random fact, so I don't think this is high yield, but let's get into it. So there's a 65-year-old, he's got this weird presentation. So he's got pain in his tonsils and his ears associated with cold liquids, and then all of a sudden he had a vagal event where he was bradycardic. So what is his syndrome? It's not Eagle syndrome. Eagle syndrome, just because I'm not going to mention any other time, that's the stylohyoid ligament becoming like ossified, and patients can't turn their neck and they get stiffness. So it's not that. It's glossopharyngeal neuralgia. So just talk about glossopharyngeal neuralgia. It's not a great, it's like a diagnosis of exclusion. We don't even understand the mechanism really well. It's kind of like trigeminal, but it only affects 9 and 10. So you're going to get pain in the ear, the tonsils, the tongue. You can trigger it by chewing and swallowing, because that's going to be the gag reflex, 9 and 10. And then of course, every once in a while it could, and this is rare, but it could elicit like a vagal response with bradycardia and syncope. So that's glossopharyngeal neuralgia. If you see that on your test, I'll be impressed. All right, question 17. A neuropathic pain condition. Oh, these are tough. You ready? Neuropathic pain condition that is characterized by summation, delayed onset, overshoot after sensation to a mechanical stimulus. Okay, they're asking you for definitions, and this is a tough one. I'll give it to you. But it's a great reason to review all these definitions. So A, allodynia. Allodynia means pain from a stimulus that should not cause pain. So you touch your face, you have pain. That's allodynia. So it's not that. So we can cross off A. Anesthesia dolorosa is actually just like its name sounds. Anesthesia, numb. Dolor, I know very little Spanish, but I do know what dolor is. Dolor is pain. So basically, anesthesia dolorosa is someone who can't feel anything, but it hurts. So that's B. You'll recognize it right away from the story. So it's not A or B. It's going to be C or D, and they're very similar and they overlap, and it's hard to differentiate them. It's either hyperalgesia or hyperpathia. So I'm going to read you the definitions one more time. So, allodynia is pain from a non-painful stimulus, like touch. It's not that. We're not talking about allodynia, so we can rule that out. Hyperalgesia and hyperpathia, if you look at the definitions, they're basically the same thing. So it's very hard to differentiate them. Increased sensitivity to pain and exaggerated response to pain. So the only realistic way to differentiate them is usually they're used in different situations. But the truth is, I don't love this question because I think it's a terrible question. I did see a nice graphic that tried to represent these, but again, you can't use these graphic to differentiate between these two because most questions they'll probably throw out this question. I don't think you can differentiate between these two. But anyway, this graphic does represent very nicely where allodynia fits in. So as you see in this graph, as the stimulus goes up, the pain goes up. So allodynia is all the way in the bottom of the curve where you have a very small stimulus and you still feel pain. That's allodynia. Then, if you follow this curve, this is normal pain. So a normal person, as the stimulus goes up, the pain goes up. And what they're trying to point out is hyperalgesia, they have pain earlier. So an example they give is like a thermal test. You put 48 degrees to the menton, and at that point, so 47 degrees, a patient will say, oh, that feels warm. By the way, we're talking Celsius, so this is warm. So 47 degrees, they'll say, oh, okay, that feels warm. And then you do 48, all of a sudden that's the threshold where it becomes uncomfortable or painful. They'll say, ouch. So at 48 degrees. And someone who says ouch at 45, he would be a perfect example of someone who has hyperalgesia. He has increased sensitivity to pain. What about hyperpathia? Usually they talk about repeating stimuli. So small repetitive stimuli adding up. And when you look at the question, that's clearly what they wanted you to go for. Summation, overshoot, after sensation. So that time course, usually you're going to hear that with hyperpathia. So that was what they were looking for in that question. Question 18. A TMJ arthroplasty has been performed. The patient, okay, this is very good. Patient post-operatively complains of flushing, warmth, and perspiration. So, do you guys recognize what that is? That is Fraze syndrome. So, this is gustatory. As you're chewing, you set off the parasympathetics, and you get sweating and flushing in this preauricular region. Now, what's the mechanism of Fraze syndrome? We talked about it last time. It's very interesting. You get aberrant innervation of the parasympathetic. So when you do the surgery, anytime you do surgery, you see this little picture of the parasympathetics. They usually go to the parotid, but they get switched and they go to the sweat glands. So every time the parotid is stimulated the parotid secretes saliva. So when you're thinking about food or you're chewing, you're eating, your parotid all of a sudden hypersalivates. So your parotid starts to activate upon mastication, but in this aberrant innervation, the sweat glands also do, so you get sweating in that area. So that's Fraze syndrome. We talked about it last time. Question 19. 3 months after the third molar surgery, the patient has dysesthesia. This is a very good question. So they're saying to you, what findings would support surgical intervention? This is something you definitely have to think about. So at what point, how do you know when it's time for surgery? So in your own mind, you should, before we even look at the answer choices, we should know what are our indications for surgery. So someone who's not improving or someone who has dysesthesia or allodynia, pain. Those would be our indications. So let's look at the choices. Well, all of them actually, unfortunately, all of them have pain. So allodynia here, burning hyperpathia, that sounds like allodynia, hyperpathia. So in all 4 of them, they're having pain. So from that standpoint, they all sound good. But then we got to look the rest of the question. It resolved with a local anesthetic. That's what they want you to get at. That's the important point. So we have to differentiate between peripheral neuropathic pain and central. If it's centrally mediated, then any neurosurgical repair that we try to do won't do anything because the neuropathic pain is centrally mediated. So how do we differentiate it between central and peripheral pain? We give a nerve block. So if the allodynia resolves with a local anesthetic, choice A, well then we know microsurgical intervention has merit. All right, next question, number 20. Which neurotransmitter plays a role in orofacial pain? So this is a tough question. I'll tell you, substance P certainly seems attractive, but so does glutamate. The answer is glutamate. This I had to look up. So glutamate is the primary neurotransmitter for pain. It's the first one to be released. Substance P also plays a role, but it requires a higher intensity stimulation for its release. So glutamate is first, substance P is to follow. All right, next subcategory. We got up to 21 already. Now we're talking about different procedures and treatment. So what results are expected 6 months after arthrocentesis? This is a very easy question. There's no tricks here. They're asking you, is arthrocentesis effective? I'm sure you guys know the answer is we wouldn't be doing it to this day. I mean, I know some old questions have some old procedures, but to this day we still do arthrocentesis, bread and butter. So of course the answer is going to be it does work. So what are the expected results? You're going to have an increased range of motion and decreased pain. Yes, we know arthrocentesis is effective. Regarding TMJ discectomy and dermal graft placement, which of the following is correct? All right, so let's read it. Dermis grafting prevents condylar erosion. Dermis grafting has not demonstrated to be superior. Dermis grafting limits the adhesion formation. So B and D are saying dermis graft is better, and C is saying it's not better. We did talk about this last time. Hopefully you guys remember. The answer is dermis grafting is not any better than discectomy alone. Right? Remember that we talked about that? We said there's all different things you can do, or you can just leave it completely alone, and studies have not shown it to be any better. So the answer is going to be dermis grafting is not any superior to discectomy alone. This is a similar question. The expected outcome after discectomy without replacement is, so very similar. Are you expecting an open bite? Well, if you were, then it would be worse. Loss of range of motion? If it were, it would be worse. A subcondylar cyst formation. So A, B, and C all say it's inferior. And we just said in the last question, it was not, grafting it is not any worse than just doing nothing. So the question is, if you do nothing, are you expecting any of these adverse events? No. So A, B, and C are all wrong. You're going to get a formation of a pseudodisc. So basically it's saying it's okay to do discectomy without replacement, because you're going to get a pseudodisc and you're not going to get any of the adverse events mentioned in choices A, B, or C. Compared to no disc replacement, the main advantage of placing a dermis graft. All right, so another question, again, harping on this point. What is the advantage of dermis graft? So it's not going to be enhanced pain relief. It's not going to be improved range of motion, because those are actually significant. It's not going to be it prevents remodeling. But yeah, it does actually, the one thing it does do is it does decrease joint noise. Okay, so all three of those questions were good review. Do you have to, when you remove the disc, you have to replace it? The answer is no. If you do a dermis graft, the only real benefit is you'll have less joint noise, but everything else is the same. And you'll get a pseudodisc. Condylotomy, so as I should mention, the joint noise is only the short term. Long term, you won't have joint noise because you're going to have a pseudodisc. All right, condylotomy. Condylotomy, immediately your mind should go to that IVRO procedure where we try to induce condylar sag intentionally to increase the joint space. All right, so let's do a couple questions about condylotomy. Condylotomy for symptomatic internal derangement has the greatest effect with which kind of patient? All right, so if you didn't already know it, the answer is going to be C. It's meant for very early stage degenerative joint. So it's stages 2 and 3. It's not going to work. It's not very effective once you get to stage 4 and 5. You kind of already knew that, I'm guessing, because we don't do this procedure if it's very advanced. If it's very advanced, stage 4 or 5, you're thinking something much more invasive. So anyway, condylotomy, it works for Wilks stage 2 and 3. Let's look at the other choices. Does it work for malocclusion? They're trying to trick you here because they know condylotomy is basically like an IVRO. But we wouldn't have called it condylotomy. If our indication was the pre-existing malocclusion, we would have just done an IVRO. So that's not the right choice. The position of a non-reducing disc, well, it depends. Is it a 3 non-reducing disc? If it's an early non-reducing disc, then actually it has some merit. But most non-reducing discs are 4 and 5, and we know it doesn't have much merit once you get to a very late stage or when you get to a non-reducing disc. It primarily works for stage 2. So anyway, next question that, for repetition purposes, modified condylotomy is principally indicated for which of the following? Anterior displacement with reduction. So the point is, this is a Wilks 2 and not a 3 or 4. And if you look at the other choices, without reduction and associated, so that now we're looking at like 4 or 5. Adhesions, chronic limit opening, perforation, that's a 5. So no, all the other ones are too advanced. So choice B is the right one. Disc displacement with reduction, like a Wilks 2. When applied to Wilks 2 and 3, modified condylotomy is effective in what percentage? So we just said it is effective, but how effective is it? Well, if I had to choose, I'm going to choose D, and you would have chosen right. Yes, it's very effective. Right? There's studies that show, I actually saw studies that show even 10 years later, it tends to, the anatomic position of the disc drops from 80 to 60, but that's still fairly effective. So if you intervene on a Wilks stage 2 and an early 3, you can get 80% of the discs. They did an MRI post-op a year later and 10 years later. 80% of the time it will be in the right position. Okay, compared to discectomy, a common complication of a mandibular condylotomy is, all right, well, this one I expect you guys to know. So when you do a condylotomy, we said it's an IVRO. It's for a different indication, but it's the exact same procedure, and therefore it's going to have the exact same complications of an IVRO. So what do you expect? When you do a condylotomy, you're going to, unfortunately, a complication of it is going to be you're going to change the occlusion. Even though you don't intend to, that is a possible complication of doing this IVRO. All right, question 29. A key technical element in the performance of a condylotomy, what in the procedure differentiates it from an IVRO? So we talked about this last time. It's D, the deliberate detachment of the medial pterygoid. When you're doing an IVRO, you don't intentionally detach the medial pterygoid, right? That is what creates the condylar sag. But in a condylotomy, you do detach the medial pterygoid intentionally in order to make a condylar sag. Couple questions about medication. So I don't actually have the whole question, but this was like, what kind of medication would you use for bruxism? And any of these would be the right answer. You could use Botox, you could use, all these are the right answer. These are not the answer choices. These are, the first line would be Botox, the second line would be benzos, the third line would be tricyclics or amitriptyline. If you reckon, if they give you any of those choices, then choose them. Those are the right choices. Therapy for a chronic central neuropathic pain after injury to the IAN following third molar surgery. All right, so this is a great question. What are you going to do? You take out their wisdom teeth, their third molars, and then they get neuropathic pain. So are you going to do surgery on them? A is basically, are you going to do surgery on them? Well, that's a trick because they said the word central. So we know surgery won't work if it's central. So it's not that. Anticonvulsants is probably right. Let's read the rest of them. Not NSAIDs. So NSAIDs do work. NSAIDs are anti-inflammatory along with steroids. But key word is chronic. Look, when it comes to chronic pain, you've missed your window to do anti-inflammatory. So steroids and NSAIDs immediately after you take out the third molar and you suspect that maybe you traumatize the nerve, you get an exposure of the nerve, and you're worried about potentially injuring the nerve, then immediately following, I would put them on steroids or give them NSAIDs because of anti-inflammatory properties. That could help prevent subsequent neuropathic pain. But once it's at the chronic stage and once it's central, the only thing that will work at that point is anticonvulsants. Okay, the mechanism of action for sumatriptan. This one I don't expect you to know. It's kind of a hard question, and the right answer is inhibition of vasoconstriction. So no, it's where is it? Oh, actually a bunch of them. Now I'm reading the questions. A bunch of them are very similar. It's B. It's inhibition of the cerebral vessel. So the point is, it's primarily targeting the CNS, and it causes vasoconstriction. Well, look, they wanted you to go with D because it has the word vasoconstriction, but it's a double negative. It almost threw me off. Inhibition of vasoconstriction. That's a double negative. If you inhibit vasoconstriction, you vasodilate. That is not correct. That's the opposite. Headaches are caused by engorgement or vasodilation. So you want to limit the amount of blood to the brain. You want to vasoconstrict it. You want choice B. So again, here's the mechanism. Triptans they all work on serotonin, and they selectively bind in the CNS, and they prevent the peptide release that would lead to vasodilation, and they cause cranial vasculature to vasoconstrict. So the right answer is, what's the mechanism of action when it comes to sumatriptan? It inhibits the cerebral vessel and the dural pain fibers. They're just trying to use words to throw you off, but that is the right answer. It vasoconstricts the cranial vasculature. Question 32, another question. This one I definitely expect you to know. Botox. What's the mechanism of action when it comes to Botox? You definitely have to know this. Choice B. It inhibits the release of acetylcholine. So, attenuation of muscle contraction through the inhibition of acetylcholine release. There's only one other choice that has acetylcholine in it, and they were trying to trick you, the reuptake inhibition. Nope, that has nothing to do with that. It prevents the snare proteins, prevent the release. Question 33. Which of the following molecules have been implicated in the pathogenesis of TMJ disease? And it can be inhibited by tetracyclines. So I got to tell you, so this has to do with the anabolic and the catabolic theory as what causes degenerative joint disease. So we know TNF, and IL-1, and MMP. So all three of them look good. So how are you going to know which is the right answer? The second part of the question. Which one is inhibited by tetracyclines? So that's a tough one. The answer is MMPs. And this is an interesting property. So tetracyclines, and I'm going to associate this with another fact, and then maybe it'll be easier to memorize for the test. So minocycline, which is a tetracycline, that we use that's arrestin, right? You guys are familiar with arrestin. We use it when it comes to big periodontal disease or deep pockets. And one of the things it can do is it can inhibit MMP. And MMP is what causes the tissue destruction when it comes to periodontitis. So again, arrestin, which is minocycline, which is a tetracycline, that works against MMPs to prevent periodontitis. So in this question, they said which of these work for degenerative joint disease, and it can also be inhibited against tetracycline. The answer is MMP. All right. Let's compare the outcomes 1 year after all these things: arthroscopy, discectomy, modified condylotomy, disc repositioning. We talked about this last time. Do you guys remember? The answer is they're all the same. Statistically indistinguishable pain relief and diet improvement. So all these procedures 1 year later, they all get the exact same relief. Question 35. We're like halfway through, guys. If you need to take a break, you're doing great. Let's keep going. 25-year-old female presents the emergency department with a medial pole fracture of the right TMJ. What treatment do you do? All right, so this is an intracapsular fracture of the condylar head. So we're going to rule out a bunch of things. You're not going to do anything very invasive, right? Usually condylar head fractures, there's just not enough real estate to do open reduction internal fixation, even if you wanted to. And again, these heal very nicely. You don't have to do anything invasive. So open reduction internal fixation, no, rule that out. Open introduction internal fixation, no. Closed reduction, maybe, but here's where they throw you off. 4 weeks of MMF, no, that's definitely not right. That's too much. When you have an intracapsular, you're either not closing them down, or if you are closing them down, you're closing them down for like a week or two, right? We don't want to cause trismus. All right, so the answer is going to be medical management with soft diet alone. And the reason for that is it's a very small, just the medial pole. The medial pole is completely insignificant. The lateral pole, maybe you would consider very brief MMF, but certainly not for the medial pole. Question 36. A 30-year-old patient presents with a history of open lock. What intervention will provide long-term relief for open lock? So we talked about this last time. Someone comes to the ED, open lock, you reduce them. What happens if it repeatedly happens? What procedure can you do? You could do eminectomy. That is the procedure of choice. And let me explain why all the other ones are wrong. So can you inject the lateral pterygoid? Yeah, that may work, but do we ever do that? No. Why? When it comes to injecting Botox, we do the superficial muscles like the temporalis and the masseter because you can palpate them and they're superficial. The lateral pterygoid, no, we don't typically inject that with Botox. You can only really do that with an EMG to identify where the muscle is because it's right next to the trigeminal nerve. It's very dangerous. So we don't go blindly and inject the lateral pterygoid. So A already doesn't sound right. Eminectomy sounds great. We know that is the procedure of choice. What about intra-articular injection with a sclerosing agent? So actually, there are some studies that talk about this. I remember we did this in our journal club. We talked about it. Can you inject PRP into the joint and intentionally induce hemoarthrosis and intentionally induce trismus? The answer is you could do that. It's not very effective, so it's definitely not the best intervention to choose. Eminectomy is the right choice. One more point about the Botox answer. The question specified that they were looking for the best for long-term relief. So besides for the technical aspect that makes administering Botox to the lateral pterygoid very difficult without an EMG, another reason why it's not the right answer is because it's very short-lived. Of course, we know Botox only lasts 3 to 4 months. So again, that would not be the best for long-term relief, and eminectomy would be the answer. All right, question 37. A 45-year-old male presents with recurrent TMJ ankylosing and an MIO of 10. So he's got a really bad case. As you can see in this picture, look at that ankylosing, complete fusion of his condyle and his glenoid fossa. All right. 5 years ago, he had a fracture. So usually trauma is what induces this. And then a year later, he underwent costochondral reconstruction. Subsequently, he went repeat costochondral reconstruction for recurrent ankylosis. And now he's recurrent again. What are you going to do? So clearly, this is the way the board likes. This is a very end-of-the-line kind of case, and the answer is going to be TMJ alloplastic prosthesis. And I say this is very classic of the boards because the way they consider, and this is kind of outdated, but anyway, from their standpoint, TMJ prosthesis is always end-of-the-line, last resort, like after you've tried everything else. And clearly, this is the case. If you're ever going to do it, this is the case. This guy failed surgery 3 times. So anyway, When they give you a vignette like that, you know what they're looking for. They're looking for alloplastic. But they're not looking for alloplastic earlier. If they give you a vignette, they're usually going to be looking for something else, and they usually consider TMJ prosthesis end of the line, refractory, last resort kind of surgery. Question 38. A 7-year-old child with a history of facial trauma at 5, and now he's got trismus. All right, so we just talked about this. So the only difference is this is a kid, and we talked about this in our previous lectures. When it's a kid, what do you do? Do you do TMJ prosthesis? No, because the kid's still growing. So that's not really a choice. And anyway, it's only his first shot. So what are you going to choose? You're going to choose costochondral graft, right? That one's easy. All right, the use of a contralateral coronoidectomy. This is the Lenny-Cabin protocol. We talked about this last time. So how do you know whether you're going to do a contralateral coronoidectomy to try to release ankylosis? At what point do you know? Do you know preoperatively? No, it's not A. You don't know preoperatively. Whether it's a CT or an MRI, you do not know preoperatively. It's an intra-op decision, according to Dr. Cabin. All right, so you're going to examine the patient under anesthesia, yes, but at what point in the surgery? It's after you excise the mass. So remember his protocol, you first release the ankylotic mass, then you do a coronoidectomy ipsilaterally, and then you check the MIO. If the MIO is 35 or more, you stop. If the MIO is 35 or less, you do the contralateral coronoidectomy. So that is the algorithm and that is the sequence. So the answer would be choice C. Question 40. Which of the following modalities have a clinical application when it comes to prevention of heterotopic bone formation? So we talked about this. The answer is low-dose radiation. It's also indomethacin also works, but those are the only two. D I actually like. Actually, I do think that's relevant. You know, if C wasn't there, I may have went with D. D is not wrong. We do know physiotherapy will help with heterotopic bone formation. Earlier activation is important. Bisphosphonates have no role, and steroids have no role. Indomethacin, which is an NSAID, has a role, but they didn't give you that as a choice. Some anatomy. Question 41. What statement most accurately describes the disc? All right, this is easy. So the disc is biconcave. That I think we all know. Look at a red blood cell. This is the shape of the disc. Look at this little schematic. The disc is biconcave. So it's not A. It's not convex and concave. No, that's not true. Is it primarily composed of type 2 collagen? Well, that's actually to throw you off. That's close because all the joints in the body are composed of type 2 collagen except for the TMJ disc. The TMJ disc is made up of type 1 and 2, and that's what's unique about our disc. But the rest of the joints in the body are type 2, so that was to throw you off. And hyaline cartilage also to throw you off. The rest of the joints in the body are made of hyaline cartilage, but our disc is made up of fibrocartilage. And that's exactly the next question. What is the mandibular condyle made of? Answer is fibrocartilage. Question 43. Very important. You have to know the planes. So what is the correct sequence of structures encountered? So when you do a preauricular approach, what do you expect? Well, this is very important. We're going to go through these planes. You're going to get skin first. Okay, that was obvious. And you're going to get capsule last. Okay, that was also obvious. And then you have to know in between these, this is the first fascial plane. The temporoparietal fascia is the first fascial plane. The temporalis fascia is the deeper plane. The way I remember that is the temporalis is directly on top of the temporalis muscle, so it's deeper. So the first plane you get is temporoparietal fascia. And then deeper, you're going to get the temporalis fascia, which has both a superficial and a deep, because it's on both sides of the muscle. You have the temporalis muscle, you have the superficial temporalis, then you get the muscle, then you get the deep temporalis. And then where does the subgaleal fascia play a role? Well, this is actually could be tricky, but you have to remember the galea is continuous with the tempoparietal fascia. If you've ever done a coronal approach, you kind of know that from doing it. So again, this is the order: skin, then temporoparietal fascia, then the galea. The galea is continuous with the temporoparietal fascia. Therefore, the subgalea is going to be below the temporoparietal fascia. It's kind of obvious. The temporalis fascia is the last fascia you're going to see, and then finally you're going to see the joint capsule. Here's a nice picture: skin. And the next thing you're going to see, temporoparietal fascia. Underneath the temporoparietal fascia, you're going to get the artery and the vein. And you're also going to get the nerve. In case this is going to be a subsequent question. Where's the nerve? It's between the two fascias. So you're going to get the nerve. Then you're going to get this temporalis fascia. Then you're going to get the temporalis muscle. Then you're going to finally get the bone. Those are the layers. Again, Temporoparietal fascia is the first fascia you see. Temporalis fascia is the deeper fascia. The subgaleal fascia is going to be right underneath the temporoparietal fascia because the galea is continuous with this, so the subgaleal is going to be just underneath it. Question 44. The temporal branch is located in which plane? All right, you guys, if you were paying attention, you know this. The answer is deep to the temporoparietal fascia, right? Temporoparietal fascia comes first, then the artery and the nerve, right? The superficial temporal artery and nerve. The artery and vein, and then also the temporal branch of the facial nerve is in deep to the temporoparietal fascia. So again, deep to the temporoparietal fascia. In a preauricular approach, where do you expect to find the nerve? It's deep to the temporoparietal fascia, and it's 8 to 35 anterior to the ear. This is an important number. We've talked about this so many times. I expect you guys to know that. Okay, one more time, in case you don't know the Al-Kayat and Bramley study, which you should know. The answer is, how much anterior from the external auditory canal is it? It's 8 millimeters, or 0.8 of a centimeter. All right. Now, when you're doing an arthrocentesis, what's your point of entry? We talked about this last time. What is the HH line, the Homeland-Helsing line? It's 10-2 and 20-10. 10-2 is the entry point, 20-10 is the exit point. So the answer is going to be 10 and 2. 10 anterior, 2 inferior. We drew that line, goes from the mid-tragus to the lateral canthus, HH line. You guys should know it. Question 48. Which statement describes a functional deficit associated with an injury of the frontal branch of the facial nerve? Okay, this is a tough one, because we're going to go through the choices. Actually, there's a couple that look right, so let's go through it. This is a very informative question. Good to know. Lag ophthalmos means you can't close your eye all the way. That's a big problem. Exposure keratitis. Well, A and B go to hand in hand, because if you have one, then you have the other. Because you're going to get a dry eye, because you can't close the eye, you're going to get dries, and you're going to get exposure keratitis. Or you're going to get brow ptosis. So actually, A, B, and C all look pretty good. Brow ptosis means your brow is like paralyzed. So which one are you going to get? You could get, the answer is, the truth is you could get all three, but which is the most likely, and which one are you going to get specifically because of the frontal branch? So now that's the key. The frontal branch is what only innervates the brow. So here's a picture. So here's right. Here's a nice picture. Right. Whenever I do TMJ surgery, I see the patient in the PACU, and I say to them, "Can you raise your eyebrows?" And usually they can't, meaning they usually have brow ptosis. That's the most common deficit. And then I say, the second question I ask them is, can you close their eyes? And they usually can. And the reason for that is because there's two branches that affect the orbicularis oculi. It's the temporal branch and the zygomatic branch. So let's just review. Remember, there's 5 branches of the facial nerve. 2 zebras bit my cookie. Temporal branch is synonymous with frontal. The question uses the term frontal, temporal, same thing. So the temporal branch innervates the brow and the eye. But the zygomatic branch also innervates the eye. So if you knock out the temporal branch, and I don't mean knock out loosely, because we almost never sacrifice the nerve, but usually because of compression and stretch, we temporarily traumatize the nerve. So you do expect there to be a deficit post-surgery of them being able to lift their brow. You get brow ptosis. You do not expect them, it's a lot less likely for them to get lag ophthalmos because the zygomatic branch will still be preserved. So that's a good question. All right, now they're asking about another important nerve, the auriculotemporal nerve. Which nerve, I gave it away, sorry. Which nerve gives sensation to your ear? I think you guys knew that. It was a very easy question. What nerve provides sensation to your preauricular skin, your ear, this whole side of your face? It's the auriculotemporal nerve. The auriculotemporal nerve, this is a tougher question about the same nerve. Which one of these is true? Does it originate from 2 roots surrounding the anterior deep temporal artery? That's close. That's a really tricky one. The answer is no, it's not that. Does it innervate the stapedius muscle? No, it's not that. So this is an old anatomy fact that I still remember. The facial nerve innervates all the muscles of facial expression plus the stapedius. It was like the outlier. If you guys remember that big graph when you were in anatomy class, the stapedius was innervated by the facial. So it's not B. Does it innervate the lateral pterygoid? No. We know facial mastication, muscles of mastication are going to be trigeminal, so it's not that one. Does it have communication with the otoganglion? Yes, that's the right answer. But this is a tough question, so let's go through them. So this is a really nice picture. Follow my cursor. Here's the auriculotemporal nerve, and then here's the otoganglion. Yes, they do have communication. Let's go through the other choices. Does it originate from 2 roots? Actually, look at this picture. It does originate from 2 roots. And then some artery goes between them. but it's not the artery they list. It's not the deep temporal artery. Look at this picture. Which artery goes right up between those two roots? It's the middle meningeal artery. The middle meningeal artery goes right up between those two roots. So it's not A. It does not innervate the stapedius. What does? The facial. And it kind of makes sense if you look at this picture. So what's this nerve coming out the stylomastoid foramen? This is the facial. And the facial is going to give you the stapedius. Just look how close the facial runs in relation to the inner ear. I can tell you, if you've ever done a temporal bone resection, which I've done, you're going to drill out the stylomastoid foramen and you're going to expose the facial nerve, and you're going to appreciate the proximity of the facial to the inner ear. So that B makes sense. As C, innervate lateral pterygoid, no, we know that's, you can even see in this picture, actually, it's a really nice picture. Right here is the lateral pterygoid, and what is innervating it? It's V3. V1, 2, 3 goes right, a branch goes right into the pterygoid muscle. So it's not that one, but it does have communication with the otic ganglion. So this is a tough question, but it was really good to review all these important facts. Next, I'll give you an easy one for a break. What's the most common configuration of TMJ disc displacement? All right, you must have heard me say it 100 times. Anterior disc displacement. I don't even know why they put that one there, but there are studies that looked at all the different variations. So anterior, like I said, is obviously the most common, 128, but you also do get cases of anterior, lateral, and anterior medial, and very unlikely you'll get cases of lateral and medial. And the reason I'm showing you this graph is because I have seen variations of this question where they ask you not what is the most common, but what is the least common. And if I had to choose, I would choose medial on this list, or lateral or medial. One of those is going to be the least common, and anything anterior is going to be common. What structures lie closest to the medial aspect of the TMJ? Very good question. So which artery is on the direct medial side of the condylar head? Which artery are you going to hit when you do your condylectomy? You're going to hit the middle meningeal artery. So here's a nice picture. This really shows it nicely. Here's the capsule. What is directly on the medial side of the capsule? It's the middle meningeal artery. Now, the other options weren't wrong. They're also medial. They're just not directly medial. Right? So let's look at the picture. The next structure that you're going to encounter after is going to be V3. So V3 is the next structure you encounter, and then even more medial to that would be the carotid and the jugular. So all the way, the jugular foramen, all the way medial and deep, you're going to get that. So the first structure is the middle meningeal, then you get V3, then you're going to get the IJ and the carotid. During TMJ surgery, preservation of the medial capsule may avoid which structure? Okay, this is repeat just to hit the point home. Middle meningeal. The roof of the glenoid fossa is formed by which bone? Okay, well, you kind of know this. I hope you know this. It's definitely the temporal bone, right? It's not the zygomatic bone. They're trying to throw you off. The glenoid fossa is temporal bone, but which part is it? Is it the petrous part or the squamous part? So hopefully this rings a bell somewhere in the deep recesses of your brain. If you chose squamous, you are correct. It is the squamous part of the temporal bone. So again, the petrous is all the way back here. This is by the mastoid process. Definitely not the tympanic, that's by the ear. The glenoid fossa is the temporal part of the squamous part of the temporal bone. How thick is this glenoid fossa? It's usually only about 1 millimeter thick. During TMJ arthroplasty, I meant to write. What structure is most likely to be the source of bleeding as you enter the superior joint space? This is different than before, but a good question. So as you're doing a TMJ arthroplasty and you're entering in the joint space, what's going to cause the bleeding? So let's go through the questions. Is it the lateral pterygoid? No, definitely can't be. If you just think about it, when we do the surgery, we approach from the lateral aspect of the condyle, right? We approach from superficial to deep. So where is the lateral pterygoid? The lateral pterygoid is on the other side of the condyle. It's medial. So as you first enter into the joint space, are you going to be anywhere near the lateral pterygoid muscle? No, that's medial to you. But the retrodiscal tissue, that's what's going to bleed. So choice C. What structure causes bleeding when you enter into the superior joint space? The retrodiscal tissue. The lateral pterygoid is going to be on the other side. You haven't got there yet. Okay. During surgical removal, you get a brisk bleed. All right. So you get a bleed medial to the lateral pterygoid. Which branch of the carotid artery is the source of the bleeding? Medial to the lateral pterygoid. Oh, okay. They wanted you to do the middle meningeal. All right. Yeah. For repetition, it's good just to say that one more time. Medial, middle meningeal. Get that in your heads. All right, next question. Where is the IMAX? And this we definitely talked about last time. So they talked about, what are they looking for? They're saying, you're doing a condylotomy. What is the maximum distance the blade must extend medially beyond the ramus at the level of the sigmoid notch to place the IMAX at injury? The answer is it's directly, it's like 3 millimeters away. So D is the right choice. You can see in this picture, where's the IMAX? Right below the sigmoid notch. If your reciprocating saw goes more than 3 millimeters, you could hit the IMAX, which is a significant risk. So usually that's why we talked about this last time. We push up on the condylar, we push up on the angle, and we distract all this condylar head up higher to push it away from the IMAX, because we know the IMAX is 20 down from the condylar head and is 3 medial. 20 down, 3 medial. So anything less than 5 and you're putting that at risk. We're getting towards the end. Question 57. Which of the following ligaments restrict posterior movement of the condyle? So this is a good review of the ligaments. The answer is the lateral ligament. If you look at the picture, the lateral ligament is the only ligament that wraps around the back, and therefore prevents posterior displacement. The other two ligaments that you should know are the sphenomandibular and the stylomandibular, and they're both oriented in the up and down position. So if you could just imagine, what do you think they do? Because based on their orientation, the only thing they can limit is inferior distension. So they prevent you from opening too much. They prevent your condyle from going down too much. The sphenomandibular and the stylomandibular prevent inferior displacement. The lateral prevents posterior displacement. Question 58. Which subnucleus of the trigeminal brainstem is responsible for pain? This is a good question. You probably remember this. This is going to be like the recesses of your brain. The answer is the subnucleus caudalis. So in the brainstem, in the medulla, you get innervation of 5, 7, 9, 10. They all meet together and they provide all of the facial sensation. And you have 3 nucleuses that sort through. In my mind, they're like sorting centers where they sort through all the different sensations. The subnucleus oralis and interparalis, they're both responsible for just fine touch. When it comes to pain, it's the subnucleus caudalis. So over here, caudalis, pain, pain. Caudalis, pain. All right, a couple of random questions. Agenesis of the condyle is a result of what? So this is actually a good question. I'm glad we threw it in here. Damage to the stapedial artery. Do you know what they're getting at? What is that? That's hemifacial microsomia. So hemifacial microsomia, there's different theories as to what the mechanism is. Whether it's damage to Meckel's cartilage is one possible, but the favorite theory is it's a vascular event, specifically damage to the stapedial artery in utero, which then causes first arch syndrome. So the first arch is responsible for hemifacial microsomia. So again, it's not going to be third arch, that's to throw you off, and it's not going to be a vitamin deficiency. So it's not C or D, it's going to be stapedial artery. It's a vascular event. MRI, what's the mechanism? How do MRIs work? Definitely an important question, but they're not giving you. So you feel like it's an easy question, but if you look at the answer choices, they're not giving you what you're looking for. You're probably looking for magnets, but they did not use that word particularly. They use radio frequency signal. That's the right answer, but you could rule it out because C and D have radiation. So this is a bone scan. This is going to be a PET. So A is a PET, C is a bone scan. So you know it's nothing to do with radiation, right? We know MRI is no radiation. So B is the right answer. Let's just review how MRIs work. It's really interesting. So first, there's a magnet. What the magnet does is it turns all the protons in our body a certain direction. So it lines up with the magnetic field. So all the protons align and they rotate into the magnetic field. Then there's a second hit, and this is what the question, they want you to know. There's not just, MRIs don't only have one, they don't only work because of the magnet. The magnet's only part of it. Then they induce a current, a radio frequency current, a pulse. They send it through your body, and that scatters those protons, and they deflect, and they go out of the electrical magnetic field. And then they turn off the pulse, and then the protons go back. And they measure how fast and how quickly those protons go back to the magnetic field. So they measure where the protons were, then the protons scatter, then the protons go back, and they're able to measure how fast those protons, how easily they scattered, and how fast they return to the magnetic field, and then based on that, they can get different densities of tissue. Then basically that's how an MRI works. It's kind of cool. Next few questions all related to an MRI. What is a low intensity on a T1 MRI? All right, so that sounds like a tough question, but if you look at the answer choices, you could probably pick it out. Because you think, at first you think, oh my gosh, I have to know the difference between T1 and T2, but you actually don't, because the answer is cortical bone. Cortical bone is low intensity on all MRIs, T1 and T2. So actually that was not so bad. On both T1 and T2, the disc and the cortical bone will appear black due to low protein density. So T1, what's going to be black? The answer is bone, because bone and disc is black on everything. But anyway, this is a good opportunity just to talk about the difference between T1 and T2. Even though this question didn't really ask you to differentiate, it is good to know. So T1, what shows up bright on a T1? It's fat. What shows up bright on a T2? It's fat and water. So the way I remember it, T1, one type of tissue, T2, two types of tissue. One is fat, two is fat and water. Most commonly we use a T1. T1 is known for better anatomy. What is the role of a T2? When does it have a role? As you might have guessed, it highlights water, therefore inflammatory changes and effusions. So again, what's the key fact to know? T1 is just better overall for anatomy, and T2 is useful for effusions. Think of water, think of T2. A couple of questions just to point that out. Oh no, we'll get to more questions later. 62, we're nearing the end. What is a contraindicated to an MRI? You probably know this from every time you send a patient to get an MRI. They ask you, is there any implantable cardiac devices? Because that could be magnetic. Titanium dental implants, no, that's not going to be a problem. Knee, no, all that stuff is not magnetic. Cardiac pacemaker, the leads could be, and that could be very dangerous. Question 63. Alright, so now if you paid attention 2 slides ago, you know the answer. What shows up bright on a T1? The answer is fat. And what's the perfect indication to get a T2? T2 demonstrates which of the following abnormalities? The answer is joint effusion. And that's it, guys. That's it for all my questions. I hope you guys enjoyed this, and I will see you on the next episode.